Hello everyone, my name's Dan and this is my reflective practice video which will look at a recent successful attempt at peripherally inserted cannulation under ultrasound guidance in our chemotherapy outpatient unit. And as part of this introduction, I'd like to mention that the Principles and Practice for Difficult Venous Access course was not the first course that I've attended, which focused on ultrasound guided cannulation. However, it's actually been the most helpful and beneficial one that I've been to. One of the aspects I want to focus on in this reflection is how this course has changed my technique and practice, and how in doing so it's actually accelerated my confidence and competence in this skill. This reflection will use Gibbs' reflective cycle as a structure for the reflection. So about a week ago in our chemotherapy unit, someone needed a peripherally inserted cannula under ultrasound guidance. A colleague of mine had already had two unsuccessful attempts, one with a blind technique, and the second unsuccessful attempt was actually using the ultrasound. The patient was starting to get a bit anxious and overwhelmed, and so I'd been called in as someone who'd had a little bit more experience with the point of care ultrasound to try and put in a cannula, what would now be the third attempt for this procedure. So moving on to feelings, I think at the time I was feeling a little anxious. You'd never like to cause harm or distress to patients, and it felt like this was the path we'd sort of started walking down a little bit. And after the workshop day, though I was keen to try a few different things that I'd learnt there and make some small tweaks to my technique. So there was an element of eagerness as well to try and see if these changes in my technique that I'd made would actually make a difference in a real life situation rather than just when practicing on the phantoms. So this brings me to the evaluation aspect of the Gibbs reflective cycle. One aspect that I wanted to change in my practice, or maybe it's better to describe it as adding an extra layer to the process, was using the long axis or longitudinal view to confirm cannula and needle position. I started the attempt by using the short axis or transverse view, selecting the appropriate vessel and the appropriate cannula given the depth and size of the vessel. And I slowly located my needle tip and using the creep method, advanced the cannula into the vessel. When I was confident that I'd advance further into the center of the vessel, I actually spun the probe around to the longitudinal view just to confirm that I was in the center of the vessel and hadn't perforated out the back wall. I then advanced the cannula in and completed my successful attempt by securing the device and flushing it appropriately. And needless to say, both the patient and I were very relieved. So moving on to analysis, I guess by way of analysis, this newfound skill of being able to help confirm placement with that longitudinal axis view made a pretty big difference. When I advanced the cannula using the transverse or short axis view, I got some initial blood flashback into the chamber, but as I crept forward into the vessel, the blood flow stopped. And I think in the past, if this had happened, I would have almost certainly either abandoned the attempt altogether or maybe sort of withdrawn a little and tried again at a slightly different angle. But I think that either of those options would have ultimately led to a failed attempt. But I remember from the workshop day we discussed that flashback and blood filling in the cannula chamber might not always happen, and to trust what I saw on the screen rather than focusing on techniques developed through years of non-ultrasound guided attempts. So I pushed on with the creep technique, slowly advancing and relocating my needle tip. And then the longitudinal view provided sort of the final reassurance I needed to know that I was in that vessel. And I think in conclusion, this added step to confirming placement with that longitudinal view made a massive difference. Not only that, uh, but trusting what I see on the ultrasound screen and not relying on my old techniques and habits. Because if I'd gone back to my old way of thinking, the fact that the blood flashback had slowed or stopped would have made me abandon that attempt, which would have made the situation worse, as my second attempt would have been more nerve-wracking and stressful, and we would have had to have been up to like this fourth attempt for the patient. So it would have been stressful all round. So I think an action plan moving forward is to keep looking at the ultrasound screen, not down at the patient's arm and needle chamber, and trust what I see on the screen with regards to needle placement. And maybe not for every attempt, but perhaps for those that are a little trickier or where I need the extra reassurance, using the longitudinal view just to confirm that needle placement and confirming that I haven't perforated the back wall is helpful before advancing the cannula and removing the needle. And as always, just keep that practice volume up. Cheers.